Hello and welcome everyone. Today we'll be discussing about the laryngeal complications that we get after tracheal intubation or tracheostomy, which are the common procedures that we do in our ICU. Now, why is this important? Patients in ICU often require prolonged intubation through the mouth or throat or through tracheostomy, which is the surgical opening in the neck. These interventions can damage the larynx and impair the normal functions like breathing, speaking, and swallowing. If not identified early, complications can delay recovery, increase the hospital stay, and raise the mortality risks. So, what are these complications? Stenosis, that is the airway narrowing, which can cause breathing difficulties. Vocal cord dysfunction, this leads to difficulty speaking, or it can also even result in complete loss of voice. Swallowing difficulties, dysphagia, increased risk of aspiration pneumonia, food and liquid entering the lungs instead of the stomach. Weak cough, it reduces the ability to clear the secretions, leading to respiratory infections. So how do these issues affect recovery? It results in delayed extubation because the patient remains on ventilator longer than they need. Failed tracheostomy decannulation because the tube removal is unsuccessful because the airway and swallowing issues are still present. Delayed speech and swallowing recovery, which can again prolong the rehabilitation process. Increased risk of aspiration and pneumonia. Higher hospital costs and mortality because the stay is prolonged, the complications are more, the patient will have multiple hospital visits. Now, laryngeal complications which are associated with translaryngeal intubation and tracheostomy. Why do these injuries occur? Even short-term intubation can cause some kind of a mucosal trauma. Prolonged intubation increases the pressure effect, leading to the tissue damage, necrosis, and even cartilage injury. The structures that are at risk are the arytenoid cartilage, the vocal folds, that is the vocal processes, the cricoarytenoid joints, the posterior glottis, the subglottic region. So these are the main vulnerable areas. So what are the types of injuries that we see? The most common would be the mucosal trauma, which can occur even if it's a brief intubation because you are introducing a foreign body. Pressure effects, as the tube stays for a long period, the cuff keeps giving pressure on the mucosa, can result in injuries. Submucosal and cartilage necrosis can occur. Perichondrial injury that affects the vocal cord support. Nerve injury, that is the recurrent laryngeal nerve, is vulnerable to compression by the tube cuff, leading to vocal cord dysfunction. Dislocation of the arytenoid cartilage, which is, it can be either anterior dislocation, which happens during tube insertion due to the forward pressure, posterior dislocation, which occurs during the extubation. So the common symptoms of extubation are stridor because of the laryngeal edema, hoarseness, which indicates there is vocal cord mobility issues, vocal cord palsy or even ulcers, vocal fatigue and breathing problems, which can mimic a vocal cord paralysis, sore throat and difficulty clearing the secretions, audible retention of the saliva due to impaired swallowing, poor cough and aspiration risk, which can lead to pneumonia. So whenever you are doing an extubation, please make sure if any of these particular features are present immediately post extubation, or even follow it up after 24 to 48 hours. So it helps in keeping track and early identifying lesions which could have developed, and this should be looked for post extubation every time. So regarding the effect of tracheostomy on the laryngeal function, direct nerve injury because the recurrent laryngeal nerve may get impaired, absent or abnormal translaryngeal airflow which reduces the vocalization ability, desensitization of the airway resulting in increased aspiration risk, glottic dysfunction, uncoordinated closure due to lack of usage, disuse atrophy of the laryngeal muscles, weakening the swallowing and airway protection. Persistent symptoms for more than few days indicate more serious laryngeal injury. Check the cuff pressure. High pressures can impair the blood flow and damage the nerves. Monitor the post-extubation stridor, which may require early intervention with steroids and nebulized adrenaline. Assess the swallowing function before oral feeds. Use FES or a bedside swallowing test always. Recognize signs of nerve injury, that is hoarseness, breathiness and aspiration risk should prompt ENT evaluation. Ensure a multidisciplinary approach with ENT physician, the speech therapist, the physiotherapist, the nurse for more optimal recovery. Impact of dysphagia and dysphonia after prolonged intubation and tracheostomy. The prevalence of the laryngeal injuries is around like 50 to 80% for prolonged intubation. Dysphonia, that is voice changes, it occurs in nearly three-fourths of the patients. Pain is reported in again three-fourths, hoarseness in 83%, dysphagia in almost 50% of the patients. So the cause of this post-extubation dysphagia is multifactorial. The cognitive impairment from the critical illness, the medications like sedatives, neuromuscular blockers, sepsis which weakens the muscles, all these can contribute to the problem. You can have mechanistic causes which are more common, like longer intubation duration, which has a risk for having higher swallowing problems, large tracheal tubes which cause more pressure on the laryngeal structure, mucosal inflammation and scarring which reduces the airway flexibility, mucosal muscle atrophy and desensitization because the coordination is not being used for a prolonged period of time. Then dysphagia is common because it is seen in around 60% of all post-extubation patients. 50% of cardiac surgery do develop a dysphagia. One-third of patients with persistent dysphagia have even after they have been discharged. So the consequence of the dysphagia is increased aspiration risk. The food and liquid can enter the lungs. The malnutrition because the feeding won't be adequate, prolonging the hospital stay and higher costs. And obviously all this will have a mortality risk. Now, dysphonia, vocal cord immobility which worsens the breathing and voice symptoms for up to 10 weeks. Laryngeal edema can cause stridor dyspnea and can lead to reintubations. Granulation, ulcerations and fibrosis which results in airway narrowing and stenosis. Severe cases resemble bilateral vocal cord paralysis leading to chronic stridor and respiratory failure. Now, tracheostomy and weaning challenges will be faced if the patient has these symptoms. Laryngeal dysfunction will impact the weaning because the swallowing is affected, the cup is affected, the clearance of the secretion is impaired. 50% of the tracheostomy patients experience the aspiration and half of which is silent without any symptoms. Aspiration increases the risk of ventilator associated pneumonia, which is again a major problem which we find in the ICUs. Psychological impact, the loss of voice will definitely cause anxiety, depression, poor engagement in the rehabilitation, inability to communicate worsens the distress during critical illness. So what therapeutic options and multidisciplinary team management we have to take care of these things? So multidisciplinary approach that we get is early recognizing and planning, which involves speech and language therapists who can assess and rehabilitate the speech and the swallowing, respiratory physiotherapists who help with the secretion clearance and the airway function, nurse and the ICU doctors who will monitor the overall condition of the patient and whether the patient can be taken off the ventilator and tracheostomy or not. Anesthesia and ENT specialists who can guide in the airway management, the surgical intervention if at all it is required. If a translaryngeal tube is causing the problem, the options include tracheostomy, which will be needed if prolonged ventilation is required, trial of extubation with non-invasive ventilation, obviously considering the risk factors involved. Managing the laryngeal edema, we can use steroids, preferably dexamethasone, which reduces swelling but has side effects like hyperglycemia, weakness and delirium. Proton pump inhibitors, which is used to reduce the reflux and the reflux associated irritation. For secretion management, excessive secretion can prevent cuff deflation and prolong the ventilator dependence. Subglottic suction helps to remove the pooled secretions, reducing the aspiration risk. Medication to reduce the saliva production like sublingual atropine, glycopyrrolate, hyoscine patches, botulinum toxin injection into the salivary glands. This can all be used to reduce the secretions. Radiotherapy for chronic hypersalivation can be done in extremely rare cases. Restoring the normal laryngeal function and voice recovery, trials of cuff deflation to allow normal airway through the larynx. One-way speaking valves which enables phonation in tracheostomy patients. Above the cup vocalization, that is allowing the retrograde airflow technique to facilitate the speech. you need to be cautious because if there is laryngeal injury or airway obstruction, then above the cup vocalization may cause facial and neck swelling. Speech and swallowing rehabilitation, individual tailored exercises for dyspnea and voice recovery by the speech and language therapist. The key therapies include swallowing exercises, which improves coordination and strength, voice therapy, which helps restore the phonation, therapeutic and oral test trials, which stimulates the swallowing reflex. We can use FES to assess the function and guide the therapy. Adjunctive therapy for recovery is pharyngeal electrical stimulus, which uses a special nasogastric tube to provide electrical stimulus to stimulate the swallowing. It can be beneficial in neurogenic dysphagia. Surface EMG provides a biofeedback to enhance the swallowing exercise, expiratory muscle strengthening, which supports the recovery of the cough, voice, and the swallowing. Surgical intervention for persistent dysfunction are vocal cord medialization, where an injection is given. It uses the vocal cord paralysis to improve the closure. Laryngeal framework surgery and arytenoid adduction, which restores the voice and swallowing safety. Other options include vocal cordectomy with the removal of the damaged vocal cords, dilatation procedure which will treat the airway stenosis, tracheal stenting for tracheomalacia and airway collapse, tracheal reconstruction for severe refractory airway damages. So post-extubation screening for dysphagia and dysphonia, how we should do it in our ICUs. It is very important that we screen for both these things because they are extremely common, as you have already seen, and they have significant impact. So early recovery helps in faster recovery and safe oral transition. Daily dysphagia screening by nurses increases oral feeding in ICU by 11%. Post-extubation pneumonia reduces by 60%. There is no single standard ICU specific swallowing tool till now. The most common one used is the Yale swallowing protocol, which includes cognitive screening, oral motor examination, and 3 ounces of water swallowing test to assess the swallowing. You can obviously use FES, which is the gold standard, but using it for so many patients in the ICU may not be feasible and practical. Clinical assessment alone, just looking at the patient based on the motor function of the limbs, is impractical because they do not actually test the swallowing muscles. Mandatory dysphagia evaluation and ICU discharge helps in tailoring rehabilitation. Screening for dysphonia is important. The voice handicap index, that is a simple questionnaire for patients to retort with voice related problems. Post ICU screening framework helps identify airway and voice issues early. Referring to an ENT and SLT if concerned about dysphonia persists is very important. Future directions in this particular field is we need more studies and the effects of the interventions like prone positioning for laryngeal edema, subglottic suctioning in reducing the dysphagia risk, newer therapies like above the cup vocalization, have pharyngeal electrical stimulus for faster recovery. All these things have to be studied. They're still at a very experimental stage as of now. So to summarize, we have a lot of laryngeal problems, the common ones being the vocal cord dysfunction, the airway stenosis, the dysphagia. So we should always screen and assess, and we can use preventive measures like cuff deflation trials, the subglottic suctioning, because the impacts are very, very crucial. So we need a multidisciplinary team which includes the ENT, the SLT, the ICU doctors, the physiotherapists, the nurses, everyone to be a part and working together. And we should also have long-term follow-up so that we can find out these problems, how they are being tackled by the patient and what we can do to improve their life later on. Thank you.